Hello, this is going to be a presentation directed at COVID-19 and some of the cutaneous manifestations that we are seeing with the disease, and really trying to help the clinician determine whether what you're seeing in the skin is a manifestation of COVID or is it truly a pressure injury? Because obviously there's different approaches to the wounds, there's different treatments to the wounds, and important, obviously, to get the diagnosis correct. I'm Joyce Black. I'm going to start out this conversation today. I'm at the University of Nebraska in Omaha, Nebraska, and I'm joined by Elizabeth Faust. Elizabeth is in West Reading, Pennsylvania, working in the Tower Health System. These are our disclosures. Both mine and Elizabeth's are up on the screen for you. The information provided to you today is provided in combination of the North American Center for Continuing Medical Education and supported by a grant from 3M, the Medical Solutions Division. Elizabeth and I are grateful to both of those folks to give you the opportunity to hear this information. So the learning objectives we are going to accomplish in this hour are to look at the various etiologies of skin manifestations and skin lesions, particularly those that stem from COVID, and try to distinguish them from pressure injuries. And I can tell you right now, it's not going to be easy. You're going to have to do some digging to figure out the actual history of this patient to try to figure out which of these it is. Obviously, some are very clear that they're COVID, and some are not. So we're going to try to give you a little guidance on that. And then I want you to finish up this conversation really looking at the interventions that you can provide to reduce the risk to the skin, and then how to treat the various lesions, be they COVID lesions or pressure injuries, or other wounds that occur in our patients during the hospital stay for COVID-19. So what does COVID do to the skin? I'm sure you've seen a figure of this coronavirus, probably like me, every night on the news. We're getting an update of the number of cases locally, the number of total cases, the daily counts, what the rate of hospitalization is. We even once in a while hear how many open beds there are. So the news is tracking COVID for us very, very closely, giving all of us, the whole public, a pretty good bit of information on the COVID story. COVID skin manifestations haven't made the news to the degree that the respiratory problems have, the neurological problems have. So we need to dig down into the medical literature to figure out what's actually going on. So the pathophysiology of COVID is very unique. If you remember from your basic sciences, the pathophysiology of virology, how a virus attacks us and how you initially attack it through an inflammatory response, and then eventually the T cell and B cell side of the immune system kick in. And you eventually develop antibodies, which are stored in plasma cells so that you never get it again. Well, I don't know that I can promise that's all going to happen with COVID-19 because we're not seeing that trend. And part of the reason is we haven't seen the disease long enough. Obviously, we know about polio. We know what happens with chickenpox. We know about those diseases. We don't have the timeline for COVID-19. As far as the virus itself, it's pretty small. It's only 125 nanometers in size, but mighty. This is a small but mighty virus. And what it does pathophysiologically is it attaches to the angiotensin converting enzyme receptors. Those receptors are found predominantly in the lung. And those of you that prescribe, administer, or monitor ACE drugs, ACE inhibitor drugs for the management of blood pressure, really know this pretty well because you know that you're hearing from patients or you're asking patients about cough. And coughing is a significant side effect of the ACE inhibitors. That's because that's where the majority of those receptors are in the lungs. So the virus is a respiratory droplet virus predominantly, and therefore enters the respiratory system via the mouth and the nose. The ACE receptors, though, are in other body organs too. So they're heavily distributed in the lung. They're also in the GI tract. They're also in the skin. They're also in the blood cells themselves, in the kidneys. And 2 days ago, I read an article about ACE receptors in the brain. So we're finding out more and more about where all those receptors are. So the virus attaches to those receptors, obviously leads to a rapid and massive inflammatory response. That's the body's normal response to any attack of any kind. Even a non-infectious attack, the body responds with inflammation. COVID-19 is predominantly driven by interleukins, particularly interleukin 6, and then two of the interferons. Interferon gets its name because it interferes with viral replication. But what happens in this story is the COVID blocks interferon 1 and 2. And so the inflammatory response doesn't get down-regulated very rapidly, and these patients stay highly inflamed, have a massive metabolic response to that, and we'll talk about that in just a few slides. The other thing that you're seeing, though, is this response leads to a hypercoagulable state. Now think back to how the body's designed. When it's injured, clots form. That's a natural response. And we see that really regardless of whether we've created an acute wound in which we want the clots to form, or we've got a bleeding chronic wound that we wish would clot. That's part of the inflammatory process. And so the clotting process goes on and accelerates ischemia because everything downstream from that clot cannot be perfused. And of course, the smaller the vessel, the greater the risk. This then becomes consumptive coagulopathy, or something we call DIC. What you are seeing in lab values are massively abnormal clotting values, massively abnormal, and are starting to recognize the value in treating these patients with pretty aggressive anticoagulation just to stop some of this basic pathophysiology. The host response to COVID-19 is really well depicted on this graphic. And the blue side of the graphic is the inflammatory response, the physiologic host response, where the macrophages try to attack the virus, try to present them to cells to get the natural immune system to work. And what's happening is it's down-regulated as a part of the virus and becomes pathologic. So at the time of the massive cytokine storm, these patients now appear septic. They develop rapid problems within the lungs because of all the fluid retention and inflammatory response in the lungs. They end up becoming intubated quickly, and what I saw recently in a publication is that within 24 hours of intubation, they start to show signs of acute kidney injury. And most of the people who have acute kidney injury and go on dialysis do not leave the hospital. So the organ failure at the end of this story is profound. And of course, all of us are hoping for a vaccine, are hoping for a functional immune modulator to try to down-regulate the COVID-19 host response, because it's much more aggressive than the average influenza, a virus, of course, we're pretty familiar with. So one of the things that's been interesting is COVID-19 in darkly pigmented patients. What we know about darkly pigmented skin is that it does not absorb vitamin D because the sunlight is blocking, the sunlight is being blocked by the melanin in the skin. And we know that darkly pigmented patients have more disorders related to clotting, such as stroke and PE and DVT, during the months when they don't have exposure to sunlight. So in my part of the world, it's from October to April, where we don't have opportunities to really go outside. We in the Midwest see the highest rate of stroke and PE in the wintertime in darkly pigmented patients because they can't get natural vitamin D. Vitamin D has a natural anticoagulant effect. And so when you can't make vitamin D through sunlight, you're increased risk of clotting. The other thing that's true in darkly pigmented patients is they don't have the same number of ACE receptors as lightly pigmented patients do. Now, you'd think that since the virus attaches to ACE receptors, that having fewer receptors would be a good thing. You wouldn't have the virus attacking at that rate. But that's not true. What happens is the virus attaches to the receptors that are there, and the response to that limited ACE receptor attachment is a much accelerated cytokine storm. So when we increase inflammation, we increase the risk of thrombosis. That's part of the inflammatory response. And then when you combine that with an elevated risk of clotting diseases due to the inability to absorb sunlight and therefore manufacture vitamin D, you get a higher risk of complications. Now, I'm not here, and don't read me wrong, that I don't think there's a socioeconomic issue in this story. But what you've heard has been highly politicized, and you will admit that. You hear a lot of politicizing about an ineffective healthcare system for people that are darkly pigmented or in lower socioeconomic status. And while that's absolutely true, there's no doubt about the disease process in folks that don't have money to manage it or have poverty as part of their existence. But this story, the COVID story, is not based on socioeconomic status. So be a little bit careful as you march forward with this, that you don't automatically assume some things and you do start to look at particularly vitamin D. Now, what I've been asked about a lot, and I can tell you from my own health, is I take vitamin D in the winter because I don't get exposure to the sun. So you may want to think about, for your own personal health, whether that's something you want to do. And you can certainly look at the literature. It will support that conclusion. So now moving into skin changes with COVID-19. That accelerated clotting process is going to lead to infarcts, particularly in small vessels, which include the skin and other body organs too. That tissue becomes ischemic, and it's true even in patients who are well oxygenated and anticoagulated. They will develop these skin lesions. I want you to look at the skin lesion on the left. When you look at that, you see a purple area. What you're looking at is the side of the buttocks. And the wound that you're seeing is in a patient that is in critical care on a ventilator. And of course, it's in a body area that's on the buttocks. So you might be tempted to say, well, it's a buttocks wound and it's purple, therefore it's a deep tissue pressure injury. Well, I'd be hard pressed to draw that conclusion unless you were to tell me that this patient was laying on some kind of toy that was the shape of a reindeer that had antlers and a tail and legs. It's not. That's a COVID skin lesion. Does it mean it's going to disappear? No, unfortunately not. That's ischemic skin. And you're going to want to try to improve perfusion to the skin, recognizing that those clots are there and recognizing that the body's ability to internally break down those clots is missing because of the accelerated clotting process. Look at the picture on the top though, different story, right? This is a patient, again, in critical care, and those wounds are on the buttocks themselves. Now, let me tell you the story here. This is a patient who had been sitting up high in bed to breathe and then was proned, and these wounds showed up after the patient was proned. They weren't visible when the patient became ill enough to be prone, so they showed up later on. So those sound more like true deep tissue injury. And it probably is. It's definitely a pressure injury. The story, though, the question that has to be asked is, was this avoidable? Could you have done anything differently to it? Now, you realize the first quarter of the year, you weren't required to submit those PSO3 numbers, but you are now. So how do you describe this thing? Clearly was a pressure injury. These are folks that are often extremely ill. They're septic, they're on vasopressors, they're vented, you're trying to improve their SATs and oxygenations, and you're seeing markedly abnormal labs. You're trying to correct the clotting process. I do want you to be aware, regardless of how you classify this as a COVID skin lesion or a pressure injury in highly ischemic skin, that these are very foreboding problems, that this purpuritic skin is very indicative of significant clotting abnormalities. And so if there's not been clotting factors drawn for a while, you need to draw them and make sure that this patient's being as anticoagulated as they can be to try to get those clotting numbers down to prevent the more serious life-threatening things like PE and stroke. There's other skin problems too. There's urticaria, and people will talk about urticaria and hives early in the disease. There are folks that report macular papular rashes, sometimes petechiae. We see modeling of the skin and the purpuritic skin lesions, particularly in the COVID ill patient who's critically ill, vented, and those kinds of things. There are folks who call these acroischemic lesions, particularly when they're in the toes, and that's a perfectly fine story too. They've actually been called COVID toes, which I think is a unique phrase, but I think it fits. These COVID toes were seen, you can see the top two pictures. Those are early skin lesions. You can see the purplish area. People who have them generally are not yet hospitalized, or they may be coming in for COVID rule out, but they're conscious enough to tell you that these areas hurt, and that's because they're embolic and ischemic. And so these ischemic wounds without blood flow cannot heal, and you can see in 7 days how they've turned into open wounds that are still going to struggle to heal. They will eventually heal if the patient survives the COVID response and obviously gets adequate blood flow back. But it isn't something that heals quickly. Again, it's a marker, at least for us, of whether what you're experiencing is the flu or is it COVID. These lesions don't appear in the flu. So if you're seeing folks early in the disease, these lesions appear early in the disease, and it may help you determine whether this is a patient with COVID or not, which will help you figure out whether the wounds you're seeing are COVID or not. So when you're trying to figure out, is this a pressure injury or a COVID skin-19 problem, I want you first to think about where the patient was positioned. So most of these folks with COVID are severely dyspneic and hypoxic. So they're sitting up high in the bed to breathe. And when you sit up high, the wound appears lower on the butt cheeks. So match the location of the wound to the history of how that patient was positioned. Obviously, in a few minutes, we're going to talk about proning people. And proning creates a whole different set of wound locations, including the face and shoulders and shins. And it's obvious that that patient got those wounds while proned. Buttocks wounds are a little harder. You're going to have to look at what position was that patient in. The delayed presentation of deep tissue injury is still true. It still happens. And so like I showed you in the case, if the patient developed deep tissue injury while they were sitting erect in bed in order to breathe, that wound's not going to show up for 48 hours. So by that time, the patient may be proned. And the staff may be saying, well, I don't know how they got a wound on their buttocks. They've been proned for the last 2 days. But put the story together, look at the position they were in, and then look at the location of the wound. The difference with COVID, and you need to stop and think this through, is that these wounds are ischemic and they may blister like deep tissue injury, but they won't have a pressure component. So you'll have two sets of wounds here. You're going to have pure COVID skin lesions and then pressure injuries that occurred in people who were ischemic from COVID-19. Well, that brings up a pretty significant question to me, is are they preventable? Let's look at some pressure maps. This is a pressure map of a patient sitting very high in bed in order to breathe. And you can see how bright red, that's where the pressure is the highest, down near the ischial tuberosities. Our beds, our hospital beds, don't often go to 90 degrees. So the highest we can get the patient with the head of the bed function is about 75 degrees. And then we put pillows behind their back to move their torso to 90 degrees, but not their pelvis. So their chest comes forward, but they're still kind of leaning back on their buttocks. That gives you pressure in the area that you're seeing the red tissue. And there's a pressure wound that happened exactly in this story. This is a patient who was sitting up high in bed in order to breathe. Now, that pressure map and that patient were not taken at the same time, because had we seen that red tissue on the pressure map, we would have certainly done something to change it. This is the COVID lesion. Now, this lesion has gone on to blister, which is very much like DTI. The epidermis sloughs off, but you have a different history and a different profile in that patient. So NPIAP came out with a couple of position papers on COVID. One is this one, the position paper on trying to help you distinguish skin lesions from the ischemia and emboli that occur in COVID-19 from deep tissue injury, recognizing, and the paper recognizes this for you, actually has some biopsies in it if you're interested in histology. This accelerated clotting is going to occur in all skin, not just skin exposed to pressure. But skin exposed to pressure that's ischemic isn't going to tolerate pressure. So that brings up this same story of unavoidability. And NPIAP did put position paper on their website about the fact that we believe that when you look at pressure injuries in critically ill patients with COVID, who are vented on dialysis, clotting factors off the limits, this issue may be an unavoidable phenomenon. You've got hospitals that are in surge. For a while, we were using the PACU as an ICU. All of those things happening, and I'm sure they're happening or happened where you are. So have your quality improvement team take a look at those wounds from a slightly different angle before they automatically assume that that wound was completely preventable, as we would look at other cases. So the skin changes in COVID-19 are common. They're common because of the clotting and ischemic process seen in COVID-19. But the pressure injury risk is always there too, because these patients are critically ill. And when they're ischemic, skin doesn't tolerate pressure. I'm going to turn the podium over to Elizabeth Faust, and she's going to talk to you about some of the unique challenges when patients are prone as part of the treatment for COVID-19 and the acute respiratory distress syndrome. This is Joyce Black. I appreciate the opportunity to talk to you today about COVID skin lesions.
Thank you so much, Dr. Black. I really appreciate that. My purpose today is to talk about interventions to protect those at-risk skins, because obviously, as Dr. Black alluded to, there's lots of manifestations of COVID-19. So one of the biggest challenges that the clinicians faced during the COVID pandemic was that our critical care population, we've been manually proning them on a ventilated patient. And while manual proning is something that's done frequently in the OR, circumstances can be different when you're in the ICU setting, and experience certainly comes into play as well. Staff is required quick education on how to safely and efficiently manually prone those ventilated patients. So why prone? So manual proning has been utilized for years in patients with acute respiratory distress disorder. It has a high mortality and morbidity, and despite technological developments in the recent years, it's one of the therapies that's proposed for the treatment is to use the prone position. It's been studied since 1974, and it's gained a lot of popularity because it improves hypoxemia in about 70% of the cases. In recent years, interest in prone positioning has resurfaced following the publication of a large randomized control trial that demonstrated significant reduction in mortality in the pronated group. And this finding has significantly increased bedside use of prone maneuver. However, there's lots of complications with proning, which includes pressure injuries, mechanical ventilation-associated pneumonia, endotracheal tube obstruction, or decannulation. The most serious fatal event is an accidental extubation, which is rare in about 0 to 2.4% prevalence. So the rationale for proning in ARDS is there's 8 randomized control trials. They've demonstrated improved oxygen oxygenation, reduce mortality with prone positioning with moderate to severe ARDS. Prone positioning in ARDS also enhances oxygenation by improving alveolar recruitment and ventilation perfusion ratios while reducing the strain on the lung tissue and the risk of ventilator injury. So the special considerations are consider the potential impact of oxygenation deficits on the risk of pressure injuries. Episodes of prone positioning usually last for about 16 hours, sometimes more, sometimes less. It all depends on the patient's needs. So know that when you're going to flip them, they're going to be flipped for about 16 hours. Make small shifts in your body position and reposition the head every 2 to 4 hours or as required by the patient. So again, looking at the patient's unique needs. Major complications of proning, as we discussed, were the displacement of the ET tube, pressure injuries, and loss of venous access. And then if prone in combination with ECMO, be very careful, secure and offload the ECMO cannula. So our facility in Eastern Pennsylvania, we developed a protocol or I should say guidelines around manual proning, especially during the pandemic. So this is our list of supplies that you'll need in order to prone. And, this is pretty extensive. So we ended up making kits, like proning kits. So this was in like a patient belonging bag that we would put all these items so you could grab your kit and then start to prone rather than being concerned if you forgot something. So you want to ensure the ET tube holder is without hard plastic parts. Some people tape. We had a commercial ET tube holder that was Velcro and zip tie based that we had good results with. You want to ensure the post-pyloric feeding tube, eye lubrication and tape. I strongly encourage a silicone tape for over the eye so that medical adhesive-related skin injury shouldn't be a concern. We had usually 5 to 6 pillows, and it all depends, again, on the size of the patient. Patients with a more prominent pannus or abdomen, a rounded abdomen, required slightly more pillows. A fluidized head positioner. So we had a pillow, or I should say a positioner, that we used for all of our post-craniectomy patients to help keep their head midline, and it was a zero flow positioner, and so we used that for the head, and I'll show you in slides later down the line how that happened. If you have it, 2 fluidized body positioners, because then you can keep them on each side. If you don't have it, you can use pillows. We used 5 large sacral 5-layer soft silicone foam dressings. Those were placed over bilateral chest, including nipples, 1 in the mid-abdomen, and then also on iliac crest. We used 6 smaller sacral 5-layer soft silicone foam dressings. Those were placed on the knees, on bilateral shoulders, and then also on the elbows. That was an as-needed thing for the elbows. It all depended on the patient. And then we also had 4x4 soft silicone foam dressings for the dorsal foot on bilateral cheeks underneath the ET tube holder straps. And then also between tubes, drains, lines, and the skin as appropriate. We used extension tubing if appropriate and 2 packs of electrodes. So the new pack of electrodes for placing the electrodes on the patient's back, obviously removing the electrodes on their on the front of their body before you manually prone them. And then just some things for helping paralyze them. So the BIS probe and monitor if they're receiving a paralytic, and a train of 4, again, if they're receiving a paralytic. Skin prep spray is just to help with any moisture-related issues, or you could use a wipe. It doesn't have to be a spray. And then 2 bath blankets or flat sheets, depending on the body's habitus. And that's to put underneath them and over top of them for rolling them when we actually manually prone. So proning is such a huge interdisciplinary team effort, and This was really one of the biggest things. So at our institution, respiratory therapy was the driver, and they dictated like when we rolled and when it was time, and they did all the counts because they managed the head. So much like when I'm in the operating room and kind of anesthesia gives the counts and kind of drives the train, our respiratory therapists were that in our ICU settings with manual proning. So of course, you want to gather all the supplies. You want to ensure that a bath blanket or fitted sheet is under the patient. You would apply all of the silicone foam dressings to their bony prominences and underneath medical devices. Ensure that all lines and extensions are in place and secure. And then just be mindful of them, that if you're proning the patient, you want to make sure that the lines don't end up underneath the patient. And then discuss with the provider the use of paralytics and sedation for proning. I think initially we used a lot of paralytics and sedation, and we found that it may not always be necessary. So just work with your intensivist on your protocols. So the steps for success are: 1, personnel roles and steps to proning. So once all personnel is at the bedside or outside of the room, the patient's ready to be prone. The respiratory therapist is at the head of the bed, and 2 to 3 nurses are stationed on each side of the patient's chest, abdomen, and legs. The bedside nurse will be the lead and direct the rest of the nursing staff. On the count of 1, 2, 3, the patient is shifted towards the edge of the bed, so they would move away. And then using the bath blanket, the opposite side is chosen for the direction of rotation. So you would tuck it under. We typically do this opposite the ventilator. The side that the ventilator is given priority, so line should lay over the patient towards that side. When the patient is turned on his or her side, you forward or toward the direction of rotation while extremities are tucked. So you keep the arms tucked at the side, close to the body, and you would roll. At this time, the EKG leads and electrodes are removed from the anterior and applied to the posterior. And then the bath blanket beneath the patient is tucked, while the second blanket and incontinence pad is also tucked. This will be beneath the patient in the prone position, and it can assist with shifting the patient towards the center of the bed in the prone position in one svelte movement. The patient will then be turned completely in the prone position, the count of 1, 2, 3 given by the respiratory therapist at the head of the bed. So the skin preparation for the head. So we apply soft silicone multi-layered prophylactic dressings to pressure points. So for us, the only spot that we hit was on the cheeks. We want to manage moisture, so making sure we're suctioning our oral secretions, and then use of skin protectants or sealants on the face. So we did use a little bit of skin protectant on the face just to help because there was a lot of oral drainage and secretions, I guess, more than drainage. You can apply a hydrofiber or calcium alginate under the prophylactic dressings. We did not do this. And you can apply thin foam dressings under the medical devices, so that's what we did. We offload the head with an offloading device, so you want to consider the density of the foam, the height of the cushion, the angle of the face, and the ET tube positioning when selecting an appropriate device. So one of the things that we really liked about our fluidized positioner is that it could immerse the head and all of the bony prominences into that pillow or positioner, and then you can also make kind of slots for where the tubes come out so that things weren't bent upward. And then we could carve out for the ear, for the jaw, for the nose, and even at the eye line there as well. With manual proning, you shift the patient's head every 2 hours and reposition their head. So we did shifts of what we call the swimmer's position, and we'll go into more details, but basically the patient was always flipping this way to that way with the elbow never going above that 90 degree. Commercial ET tube securement devices can contribute to increased breakdown if they do have that cheek or the harder plastic on the front with the cheek securement. I would say avoid using that commercial one that has increased pressure there. You want to make sure eyes do not obtain corneal abrasion, so you want to apply ophthalmic lubricant and tape the eyelids shut horizontally if possible. Again, silicone tape is the recommendation. The tongue was one of the things we had the hardest time with. To ensure the tongue is inside the patient's mouth, a soft bite block may help. The tongue was often what we found protruding. It would develop edema and then would stick out, and we would have a hard time getting that swelling down. And I think part of that was because of proning, part of it was because of the disease process and body habitus. Sometimes we could use a bite block, but it was so hit or miss. But making sure, trying to at least recognize that keeping the tongue inside the mouth is what's best. The torso, so you want to place the EKG leads on the back while proning. Apply prophylactic dressing to the pressure points on the front of the body. Ensure central lines, arterial lines, and cannulas are secured. So we use catheter securement devices, usually on the anterior thigh for all patients. So obviously when proning, we would have to remove those and we wouldn't worry about the securement necessarily. You would make sure you empty any ostomy pouches and pad around the stoma site. If the patient's receiving enteral feedings, you want to turn the feedings off about an hour before just because of the movement. And then secure all tubes and devices away from the skin, protecting the surrounding skin with prophylactic dressings and bridging areas with positioning devices. And then create the channels for tubes with the positioning aids and ensure there's no unsecured devices under the torso. So when we talk about the genitalia too, we'll talk more about making sure the catheter is not underneath the patient. So for the legs, breasts, and genitalia, we would apply prophylactic dressings to pressure points such as the patella and the pretibial area. We would remove securement devices that align the urinary catheter or fecal management system and just bring those directly down towards the foot of the bed. Ensure there's no unsecured devices under the legs, offload the feet. And breasts and genitalia are particularly sensitive tissues that should be offloaded and protected. So we would often, after we would prone the patient, we would kind of separate the legs and ensure that the genitalia wasn't pushing onto itself to worry about skin necrosis from its own weight. And same with the breasts, that they weren't pushing down, because you can see some nipple necrosis. Now, we would put the 5-layer silicone foam border over the nipple area just to additionally help with that as well. Here you can see in the photograph the proper positioning and padding for feet. So this patient was prone. We ran a pillow from patella to dorsal ankle, and then we used the wedge to help keep the feet upright so that the toes didn't hit the surface at all. And we found really good success with that option for preventing any lower extremity pressure injuries. The patient's head is turned and placed on a fluidized head positioner should avoid direct pressure to the ears, lips, and nose. The ET tubing can have channels created within that positioner, which really helps create stability. The orientations of the arm should be rotated along with the head every 2 hours. One arm may be positioned up, however, the elbow should not be placed superior to the shoulder, and then the opposite will lay at the side. So again, that swimmer's position. The patient's back should be assessed for a neutral spine, and the pillow may be necessary and placed below the patient's neck or underneath the chest if the chest is larger. So we would place additional pillows like underneath the body to help lift off some of the weight of the body itself. If a dip appears in the lower back when the patient is lying flat, pillows beneath the pelvis may be necessary. And when turning, the pillow should be placed beneath one side of the patient that you supine them. So if the patient was facing their left, and this is my left, you would place pillows underneath the chest and the hip on that side to help lift up their body slightly so that they can expand their lungs even better. Patients that have a larger abdomen or are of a heavier weight may need additional pillows. And then pillows should be placed beneath bilateral lower legs, ensure the heels are not touching. The wedge can be used on the anterior ankle with a pillow to help offload the toes. And then again, ensure the patient is not laying on any tubes or lines. Here's an example of the swimmer's position. It's a standard prone position, and then you can reposition in the swimmer's position for head and arm offloading. You want to alternate the position of the arms and direction of the head in a style that is similar to that of a freestyle swimmer. The pressure points in the diagram correspond with a body surface facing the mattress, so you can see all the points that could likely cause pressure. Some skincare tips. So soft silicone foam dressing should be applied to any bony prominences that has contact with the mattress, iliac crest, knees, dorsal surface of the feet. The large silicone border dressings can be placed on the medial abdomen. We found that this helped prevent blisters that we found developing from shearing, from either turning side to side or when they were in their reverse or their Trendelenburg position. Additional border dressings can be applied to areas that may be vulnerable, like beneath tubes, drains, lines, things like that. And then you can use a pressure redistribution surface if they're not already on a bed designed specifically for proning. So we used all low air loss mattresses for our proning process. Some additional skincare tips: follow the manufacturer instructions always when using beds, positioning devices, prophylactic dressings, and other products. Position devices and pillows are needed to offload the pressure point. So don't walk into a prone room and only have 2 pillows because patients will likely need 5 or 6. Involve enough trained staff to avoid friction and shear when repositioning. You may reposition into a swimmer's position. And then assess all pressure points. So prior to proning, make sure you're checking the skin, noting any anomalies and appropriately addressing them. And then when alternating the arm position and the swimmer's position, assess for the skin integrity of the head and face, and then document any skin assessments and preventative measures. We also used an additional wicking pad underneath the face just to help manage some of the secretions. Here's placement of preventative dressings on the body. So you can see this is our commercial ET tube holder on our mannequin. And we placed traditional soft silicone foam underneath that across the cheeks, avoiding the strap overlying the ear if possible. You can see the placement of our sacral silicone foam dressing with border and our dorsal foot. You can see the 4x4. And then this is what the head positioner with the swimmer's position looks like. So you can see in the upper right-hand photo that the patient has the EP tube and we cut out a channel for it. And you can see it's the arm, you face the arm that's up, and then the elbow is not higher than 90 degrees. So just some tips for using the fluidized positioner is to carve out a channel for the EP tube holding so that it lays in it and is immersed rather than pushing it upward so it doesn't cause additional pressure on the lip. Build up the positioner to give proper height based upon the patient's anatomy. Obviously, the larger the patient, the larger the head, the harder it is to move. Use your hand to push the positioner down around bony prominences. So you can actually take your hand and sneak it underneath the patient's head, push down on the positioner and to ensure that there's like a carve out for the ear. This creates a dip in the pillow and can prevent additional pressure. And then once the head is rotated, ensure the chest rises enough that the head is able to be aligned. So if you're having a hard time moving the head, or if you feel like you might need to lift the chest up with some additional pillows just to give you that extra space. If they're pressed too far in, it's really challenging to flip a head, especially while they're intubated, because you don't want to put any additional pressure on that tube. Great. So I appreciate everybody taking the time to attend our webinar. Please complete the evaluation to obtain your certificate. Thank you.